Welcome everyone to our first presentation that features one of the best publications in improvement. This publication was rated the highest scoring in the healthcare worker division of the award. And we are so excited to have multiple of the co-authors on the call today. Karleen, Carl, Wendy, and I'm sure there's others, but very excited to feature these publications, and more talks on the award winners will be coming up. I'm Samantha Kling. I'm from the Evaluation Sciences Unit, and I'm happy to introduce first Carl Lorenz, who will be introducing our amazing speaker today. Carl is a internal medicine and palliative care physician and section chief of the VA Palo Alto Stanford Palliative Care program. He is also a researcher at the VA Center for Innovation to Implementation Center, and previously served on the faculty at UCLA School of Medicine. And I'll hand it off to Carl to introduce our speaker today.
Thank you. I am so excited to be able to introduce Dr. Karleen Giannitrapani. Karleen is a member of the Faculty of Primary Care and Population Health at Stanford and spends a majority of her time at the VA Palo Alto, where she's an instructor for the Center for Innovation to Implementation. She helps to co-direct. She's the co-director of the VA's National Quality Improvement Resource Center, which focuses on improving palliative care and support for older veterans and their caregivers. She studied at UCLA. Her first degree was in African Studies. She has 2 degrees in public health with a PhD from Health Policy and Management that focused on organizational science. She is the recipient of a very prestigious 5-year VA Career Development Award. And her areas of expertise are numerous, but notably, she has deep knowledge, experience, and interest in implementation science, in global health, and especially in the science of how teams work together, especially multidisciplinary teams and teams on the fly, which of course is a pervasive issue for healthcare. She applies these skills to pain management, palliative care, including its use and integration with surgical services, and communication, health communication, including goals of care. And I will mention one personal attribute, which I think also is outstanding and amazing. And she is the only person I know who can stand on her head and still lead a meeting, because she is an incredible yoga instructor, which I know from having taken one of her classes and having been unable to follow all of her moves. But anyway, she is a multi-talented individual, and certainly someone that is wonderful to have around and adds so much to our science and understanding of health. Thank you.
Well, thank you very much for that introduction. And thank you all for the opportunity to share our work. You will notice that the topic of this has nothing to do with anything Carl mentioned in the introduction. And I guess I'll just take us all back to, did anybody else work on anything during COVID that wasn't part of what they usually work on? So I'm really going to share my COVID pivot project with you. And I think it really just, it was a testimony to how much innovation was happening at that time, and how so much about good health services research and implementation science is about team, because we can take these skills and translate them to the most pressing problem at hand, which for me during the pandemic was supporting the role of occupational health in VA, and I'll explain that to you why in a second. So this is, I'll give you the parent study, but this was a secondary analysis or in response to an already ongoing parent study about how we could better facilitate the role of occupational health in VA during COVID. And one of the things that really came out of that was their role in supporting the dissemination of vaccination campaigns, and how, if we could figure out how to do cross-system learning in this 170 facility national infrastructure, it was really advantageous for not only employee health working in these situations, but all the healthcare workers that they were responsible for and serving, and then all the patients, and then, community at large. So, I have no conflicts of interest, and I'm very findable, Karleen at Stanford.edu. And this project was funded through a VA HSR&D, Health Services Research and Development Rapid COVID Pilot Project. So you might recognize some of the members of our team: Sarah, Carl, Wendy from our department. Becky Yano was on my dissertation committee. Katie Brown Johnson, I really leaned on for a lot of the primary data collection on this. And thank you very much, Katie and the ESU, for your help during this project. And then you might notice on the second line, a name that looks pretty similar to mine, Susan Giannitrapani, that's my mother. And she was the lead of occupational health at her VA hospital in Wilmington, Delaware. So the first couple weeks of the pandemic, this was a very scary personal problem for me, because the policies weren't set up and in place such that people knew where to go if they had COVID. So there were literally possibly infected people coming into my mom's very, very small office. And so this was what do we have to do from a workflow perspective? What do you have to do from a documentation perspective? And this is what I was living in my family conversations at home. So when this rapid pilot COVID project opportunity funding came out, and I had the opportunity to address this issue that I was really passionate about, which was the role demands, the expanding role demands and needs of employee occupational health for VA during COVID-19. If we were going to do this for one hospital in Wilmington, Delaware, I was like, well, Mom, should we try to do this for the VA nationally? And so that's how this project came to be. So the parent study was really a national evaluation to use as rapid methods as possible to get insights back to the field for task force that could work on things like staffing and changes in needs. And it was, on March 15th, the U.S. Deputy Undersecretary for Health and Operations circulated guidance allowing asymptomatic healthcare workers exposed to COVID-19 to continue to work, because this was very necessary at this time, after consulting with employee occupational health. So occupational health was thrown into this central role in COVID management, and it was a very entrepreneurial site-by-site situation where they were figuring out, well, what do I need to do? How do I do this? What is the CDC guidelines? And so there's a lot of repetitive type of problem solving happening across these different institutions, a lot of innovation and a lot of stress. For those of you who aren't completely familiar with the VA, I know many people are, but occupational health probably serves 500,000 healthcare workers, trainees, and volunteers nationally. And these healthcare workers, in turn, are serving over 9 million veterans in community living centers, which are like the VA nursing homes, as well as the 170 facilities across all of the states and territories. So the reason why this was such a pressure on occupational health, I think, is because in the VA hospitals, for the non-healthcare, non-frontline workers, people were being sent home. But when you think about healthcare workers, this is basically all of the employees that you're working with and serving are being thrown into the very high risk of exposure all at the same time. And so while a lot of industries have the luxury of thinking about how do we stratify risk and only have very few people exposed, the challenge facing the people working on protecting healthcare workers in VA was, how do we protect everybody and still provide care to all of these patients? And so we had to go fast. So we leveraged role expansion theories and implementation science theory, specifically CFIR, to inform a rapid interview guide. And the themes that came out of this initial evaluation were broad and targeted. So they happened to both the micro and the macro level. So we needed infrastructure to support population management at both the local and the national levels. And for example, what I mean by that is if this were about tracking what was happening with patients, well, we already have electronic medical records in place. For employees, we didn't necessarily have centralized databases where you had contact information and vaccinations and N95 mask fittings, all already with the infrastructure already built. So you had these very entrepreneurial databases set up that weren't always talking to each other. And so how could you set that up at one site? How could one site learn from another? And this brings us to the second theme, which was people were asking for mechanisms for information sharing across sites. And one of the things that the employee occupational health community in VA had is actually a shared listserv forum, which historically at sometimes has had a funded FTE split between multiple people where they could, and I think Wendy Tonnesy, who's on this call, was one of those people at one point, could respond to emerging concerns as they came up. And particularly, when you think about the variety of the types of providers running occupational health programs, if it's a very small clinic in a very small setting, you might have one nurse practitioner. If it is a large healthcare system like VA Palo Alto, you might have MD, employee occupational health trained providers and NPs and supporting nurses. So having access to expertise across the system really, I think, was supportive for smaller and rural sites. Obviously, number 3, sufficiently resourced staffing. And this meant that there had to be a way to understand, per patient or per employee need about how much occupational health staffing needs were there. There weren't consistent staffing models to empower the frontline healthcare workers to say, or employee health workers to say, I really need more people. I'm being asked to do this many things, and people aren't getting detailed to support us. And so when you think about workload capture from a patient level, you can really quantify, well, I'm seeing this many patients, I need this much help. It's really hard to do if you're not monitoring that at the healthcare worker level. So we started thinking about how we would capture the workload associated to the care needed for employees. Connected and resource local and national leaders, and then mental health needs and employee occupational health's role in supporting the mental health of providers as they were, burning out, getting sick, getting overworked. Their patients were dying, sometimes other healthcare workers, and they're dying. And there was not that pause moment for bereavement that there traditionally might be in other moments of time. So I'll bring you then to this paper that we're discussing today, which is understanding the barriers and facilitators to early COVID-19 vaccination. We were already in the middle of this rollout of an evaluation of the needs of employee occupational health, and then all of a sudden a vaccine gets approved, and then there's a vaccine need to distribute at all of these sites. And employee occupational health had a very very important and central role in the delivery of this. But if you think about, I just explained to you 500 new things that they were doing, and then you have to layer on top of that another task. People were pretty strained and overextended by the time the COVID-19 vaccination campaigns were even starting. So we aim to identify what these challenges were for implementation, that the employee occupational health, what their own barriers to their own role in facilitating vaccination, and then also the barriers they perceived in getting the vaccines to healthcare workers. And we basically just kept talking to people. So, wave 1 was our initial intended data collection, and Katie Brown Johnson just kept talking to people. And we got a whole nother wave of interviews to address this emergent problem, which was, what do we need to understand to support the from the data that we have and the resources that we have, the rollout of COVID-19 vaccine dissemination to healthcare workers. All right, because time was of the essence, we were using rapid qualitative analytic approaches. We were trying to go as quickly as possible. By the time we published the paper, we went back and did more standard qualitative content analysis as well. But we got pretty close with our rapid analysis of 38 key informant interviews. And that second wave of interviews really probed for specific vaccine implementation related challenges. We talked to a lot of people. We made sure that they were distributed across the roles of employee occupational health and also areas within the VA. So this was purposely going for as divergent of a type of perspective in terms of representing their settings. So our strategies that emerged kind of clustered into 5 key domains. The first was recognizing the importance of leveraging multidisciplinary effort, and specifically diverse skill sets in multidisciplinary effort. The second one was the need to be really focused and invest in process that aligned resources and priorities. And I'll spend a little bit more time when we go through the quotes on these first 2, because there's so much about what we learned about COVID-19 in this crisis moment that is about preparation of caring for healthcare workers and healthcare systems in any time of crisis, in any time of potential infectious disease situation. And hopefully we don't see this again soon, but maybe we will in the course of our careers. And so what are the learnings that from this period that really also extend beyond specific COVID-19 related issues? The third thing was the need to expect and accommodate vaccine buy-in occurring over time. So if you think about like a standard diffusion of innovation curve, you have your early adopters and then more people, but as with any implementation of a new innovation, there are always tail populations. There's always a second half of the population. And so expecting that and accommodating that and figuring out what facilitates that, I think, is a helpful lens to take through thinking about how do you facilitate something like new vaccine buy-in that will occur over time. We need strategies to overcome misinformation through trustworthy communication, and the health system really has a role to play in that. And then thinking about how do we leverage existing and develop needed, newly targeted communication channels to foster sharing of information and learning across teams and sites in the way that it's needed at that time. So there was this tension between what's already in place, what can we use as quickly as possible, while simultaneously figuring out what's the best thing we need, what's the best path for that, and putting that in place. I have a few quotes that I like to share. This was from theme 1 about leveraging diverse skill sets through multidisciplinary efforts. It's not just nursing that's coordinating this vaccine administration. It's multidisciplinary. It's also about education. And those employees from social work and education have been very responsive. So a lot of the examples that we saw, particularly for the later adopters, leveraged approach of talking to people from multiple perspectives. Focus like a laser, invest in processes and align resources with priorities. We needed more staff to help, more hands to do the work. Yeah, more leadership support. They had to approve the extra hands, and that's been critical. And we saw positive and negative examples of this, of sites that really had the resources to detail people. Detail is just a way of saying taking someone that's assigned somewhere and assigning them to occupational health. And occupational health at some of the sites had real challenges getting people detailed to them versus keeping them in patient care. We suspended almost everything else. Luckily, they've suspended for a while, not having to do the pre-employment physicals. These are like other role demands that weren't time sensitive and COVID specific. You can do those later. But if you think about what decisions a frontline team member can make versus what decisions you need help and support from your leadership to make, it was really those types of decisions where you had the permission to say, this has to happen now. This can happen later. We are focused like a laser on these are the things that happen now. And we have support at all levels of the organization, from the frontline team up the leadership chain to the policy and decision makers, to focus on those priorities. Started talking about this a little bit, but expect and accommodate slow buy-in occurring over time. So this was a quote that I really liked. The buy-in came because people in our facility were getting it and not having side effects. And then it was sort of like a tsunami with everybody. Okay, well, you get yours, I'll get mine. And this was from a quote that was very early on. You needed a few early adopters at the sites. And then people needed to see nothing bad happened. And then acceptance kind of swelled. Another quote about overcoming misinformation through trustworthy communication. It's not mandatory. I can tell you what literature I've seen. I can tell you what I've found. I can tell you what folks have experienced. Bottom line, it's your call getting the vaccine. The recommendation is I can see if I can find additional literature to help you make the decision, but ultimately it's your call. And this was an NP talking about how they wished they had resources that they could facilitate these conversations over time. You know, I do a lot of work in the palliative care space. It's kind of like the goals of care conversation where everybody's talking about, like, it's iterative. You can't expect somebody to come in and have this conversation all at once. And I think, you know, if you're a healthcare worker and if there's an expectation that you have to do this right now, one of the big gaps was that there wasn't this time to go through the quagmire of information that was facing people in their personal lives, in media, and then come in and have those moments of conversation with employee occupational health to say, yes, you can do this, or yes, how can I support you towards making this decision? And then finally, using newly developed communication channels to foster sharing and learning across teams and across sites. Here's a quote. I mean, we had to really think outside the box to come up with a solution, but it would have been so nice if people brainstormed together. And this was from an MD at a site where they didn't have a lot of other people at the site, or they weren't talking to people from other sites. And this was really in contrast to sites or people who were very engaged in information sharing through like the shared listservs, and also just recognizing that, you know, relationships really matter. Like people who had relationships with nearby facilities. For example, there was conversations between Philadelphia and Wilmington and Coatstown. These are places in the Pennsylvania, Delaware, New Jersey area where they had a kind of community regional level conversation going on, supporting each other. And you could see, you know, differences between sites that had other sites that they were closely aligned with and making decisions with and talking to, versus people who were a little bit out on their own and didn't have that type of community or support. And so, tight to this very specific analysis, vaccines weren't mandatory. They're now not mandatory. And so figuring out the strategies to empower healthcare workers to choose vaccination is key. Expecting some slow vaccine buy-in allows providers and systems to tailor approaches and prepare. And so, you know, now that we're in this phase of COVID is just finally now not an immediate emergency, but we don't know what's coming next. What does this mean in terms of being prepared to help systems rapidly be able to respond in real time to tailor approaches and prepare when new information needs to be spread, when new innovations need to be delivered and disseminated in real time very quickly for the sake of, public health, not just patient health, not just employee health, but taking care of the community at large. And, what do we need to think about from a system and cross-site information sharing perspective to better facilitate brainstorming and learning? The examples that I was discussing in this talk were from, sites within a system, and how we were sharing information and how some of the smaller sites could learn from what was happening at the larger sites or geographically proximate sites. But how do we do this as a research community? How do we get high quality evidence disseminated quickly so that, VA Palo Alto and Stanford are in an ecosystem where you're sharing information in real time, and, other ways where we still have quality checks on what's being disseminated in a way that we didn't on all of the preprints, but that we really have a way to do it very, very quickly. And so beyond the clinical implications, because this is the world that I sit in as an organizational researcher with background in organizational behavior, organizational theory, there are implications not just for clinical practice, but for theory here, in that the strategies that employee occupational health highlighted, they're occurring across these different levels. So individual, interpersonal, and then also organizational levels. And so when we go to think about using theory to inform innovation and innovation dissemination in the future, really separating out a priori or what level and lens are we talking about, I think can help, and was one of the reasons why we were able to effectively leverage rapid analysis to get insights very quickly back to the field and the occupational health program office in VA. Another interesting thing that came out of our results was how identity-aligned communication may really help with buy-in. And when you looked at what type of conversations people needed to have and who needed to be having those conversations, and facilitating the slow buy-in over time and having the time to have those conversations, where was the real added value? Identity aligned doesn't mean identity concordant conversations. It means empowering people and connecting with them through the voice of you're a healthcare worker. Sometimes if you invoke the identity of we're a healthcare worker, we're protecting the patients that we're serving, it helped anecdotally providers support healthcare workers along the decision to get vaccinated, regardless of what other identities they had where vaccination was not a priority, or was something that they were socialized was a challenge. And another example that goes along with the facilitating of the vaccination was the hyper-local testimonials were helpful in aligning healthcare worker community in a facility, so spurring vaccine acceptance. And so I think we've seen that now in the literature. There was an example in this setting, but I think we've seen it in other settings now as well. So how can we in the future facilitate, understand the power of hyper-local testimonials and think about that as anchoring of facilitation strategies for dissemination campaigns on other issues. Before I end, I will share some of my thoughts about future directions from this work, which is, so practically in VA, some of our recommendations are already being enacted, particularly from the parent study about just the importance of workload capture of what the providers who take care of providers actually do and how much work that takes and how much time that takes and what value that is to the healthcare system, such that there are ways to advocate for better staffing models for employee occupational health across systems. And then I talked a little bit about what we learned about the role of occupational health and how this can help us prepare for future times of crisis and organizational uncertainty. I think employee occupational health was always doing a lot of these things, but there wasn't a lens being shown on the importance of the role within healthcare systems. And they serve this very central place where they're both an agent of the organization, and that they're protecting the organization and the goals of the organization because they're protecting workers within the organization. But also the employee occupational health providers themselves are workers too. And so what were their needs and what do they need from the system to be able to, adequately do their jobs in the times where it is burdensome, or there's high burnout, or there's lots of uncertainty. We very early on in this project had some of the nurses saying to us, this was a scarier moment of time than at the beginning of the AIDS epidemic because the healthcare workers are dying, like my colleagues are dying. And so I think there's a lot of additional work to be done to think about the role of that, the ways that the roles of healthcare workers need to be supported in advance of future crises. And an extension of that is specifically, what is an employee occupational health role in helping with healthcare worker mental health, even if it's just formal pathways to connect employees to employee assistance programs or other crisis management resources. This is one of the things that we're working on now as an expansion project of this work. And so I will open it up for questions and comments there, and maybe I'll stop sharing unless there's anything else anybody wants to see.
Thank you, Karleen. That was great. A lot of lessons learned from COVID, and the VA is a very interesting health system, I think, in that learning that information's disseminated across in some areas like the Pennsylvania, Delaware, and whatever the third state was. But I start with the questions, what are there mechanisms in the VA to share across organization, or is it just like here individual occupational groups coming together and setting up that infrastructure?
There are, and I'm actually going to invite Wendy to speak because she had a very important role. She was an occupational health lead at Palo Alto VA during this time. So Wendy, why don't you take that question?
It's a great question. Thank you. And thanks so much for a marvelous presentation. Thank you for representing, and I put this in the chat, both our employees, which we spend our lives taking care of, but also the occupational health personnel who take care of our employees, which is sort of a marginalized group in some settings. So at the VA, the communication patterns are really nice. They can be both within your own entity, then within your region, which is called a VISN. So our VISN 21, of which Lisa Freeman on this call was my director of the Palo Alto VA healthcare system. Our region went all the way out to Guam and Philippines and over to Nevada. 22 VISNs in the nation. And then there's also a communication center within the nation, at least for the occupational health group. So we have national listservs, and then we have VISN listservs, and then we have local listservs. So we had a lot of ways of getting information and comparing that I think is really the saving grace of occupational health in that system. And a really interesting way to know what's going on with other areas. So I think that was a real key to working in that system, is you didn't feel alone.
Well, and Wendy, tell them also about the funded FTE divided between multiple people, where we actually at different times historically have had somebody to answer questions to different people, because the occupational health represents a range of professions.
Yeah, that's a great question. So there was a time, there was about 5 years, where there was a cohort of 5 of us, 5 or 6 of us MDs across the nation who had sort of lanes. So they took one FTE in Washington, D.C. central office and gave 5 of us 20% FTE to be specialists. So I was infectious diseases. So TB and vaccines, this was my sort of my lane. We had another lane that was agency required physical, so fitness for duties, police, deployment exams, a lot of policies and laws and regulations about that. That was somebody else. There would be another person who was vision and hearing and exposures, because that's a whole nother lane. So there were 5 of us who were the subject matter experts. And with that 20%, the nation could contact us, anybody in the nation, and ask us questions. And that would be on the listserv. But when they put the question out there, that subject matter expert would sort of have a lane to answer those questions. And there was a centralized location for that didn't work as well as the listserv, but it was nice to have designated experts that people could go to. And I certainly used my colleagues all the time to ask them questions.
Thank you. And please feel free to put your questions in chat or come off mute and ask any questions you may have. Richard, would you like to say your question out loud?
Yeah, certainly. What's your impression? Did you get any impression at all what leadership really played, how that played a role into people accepting or becoming more accepting of vaccination? Meaning, like for myself, I was one of the first wave, and I actually put it out on my social media, me actually getting the shot, and the second one, and the third one. What was there any sort of messaging coming from high level from the leaders? And I'm talking about, your executive leadership levels. And would that, you think that would play a role in helping to facilitate vaccination acceptance, going forward for, what we all know is going to happen again sooner or later?
I'll speak to it from a data perspective, and then I'll turn it back over to our clinical team members. So we had very different stages of rollout, which I think reflected very different stages of communication need, and also very different stages of infrastructure needs. So at the very beginning, I think that much of there was support from leadership, but what did leadership mean? Did leadership mean central office? Did leadership mean the facility? Did leadership mean the person at the facility who could designate the resources to have enough people to do the thing? Did it mean there was a trade-off between who was helping with vaccination campaigns versus who was helping with all of the other needs that occupational health was staffing during that time, including both COVID-related and non-COVID related tasks? Because you think about the realm of employee occupational health, there's everything to do with testing, contact tracing. Anytime there's some type of problem that happened in a community living center, people are still falling and getting hurt on sites, and there's reporting that has to be doing about that. And so I would say one of the biggest needs of leadership very early on was helping employee occupational health navigate time to be participating in these tasks. And so maybe the employee occupational health need, it took a while for the issue to come up as communication, and it was really just purely workload and FTE. And then as people started getting support and detail to the site, and time went on, and most, the early adopters were vaccinated, and then the middle curve was vaccinated. I think there was support from central leadership at a bunch of the different facilities to figure out how do we get the rest of the healthcare workers vaccinated, and that was definitely a priority. But,
I'd say thank you so much. Two learning lessons that I would take away from that we definitely could have done better. And I think from what I hear from Ann Cullen, my colleague who's on this, who was really part of the stand-up at Stanford, was two places that Karleen mentioned. One is that this permission from leadership to work later. These are the things you can take off your plate, even though they're usually mandated. You can take them off now, we'll do them later, was a great idea. It wasn't great in practice, and we never did it. We continued to do everything that we were mandated to do because there was actually no way to go track those people down later to get them to do physicals or get their TB tests. Like that would have created so much extra work, and we weren't allocated staff for after the pandemic. So the permission, I think, worked differently for different areas, but it was a great idea. And it would be a great thing for leadership to do, is to help, if you can't give more staff, to unload some of the responsibilities. The other thing I would say is that one failing, and that we need to talk with CDC and ACIP about, was while healthcare workers were given first priority for vaccine, you all remember that, right? Occupational health was not listed in the first group, which means my staff was standing in an auditorium with 450 people coming through it every few hours to get their vaccine, freaking out because they weren't given priority to get their vaccine first. And that was a mistake. And thankfully, Palo Alto leadership does listen, and they are responsive. And, we were easily able to make our case that our occupational health staff had to be vaccinated on the first round before they stood in a room with hundreds of other healthcare workers. But it was an interesting oversight on a national level. And Karleen, I don't know if you picked that up.
Yeah. Again, kind of tangentially gone around the question. I was just basically looking at how would you view leadership, and like go back to where I was working at the time, Madigan. It was really the physicians and the nurses who stood up. The physicians kind of led the charge to get vaccination and get people to accept it. So that's more the essence of my question is how do you break down that resistance? Because there's a lot of people saying, not a way. I'm not going to do that. In fact, one of the comments that came back on my Facebook was, maybe I'd turn into some little green man, hairy man, and melt away and look like some sort of a, alien or something like that. They were going to wait. But then there was a group of people that I work that I know, they're professionals, who had been resistant, and they said, okay. So I just put the evidence out, of the effectiveness of vaccines through history. I wrote this little article and put it on there. And next thing I know, they're saying, yeah, they're going to go get their shots. So that's kind of the question that I was alluding to, because, there's still a lot of resistance to vaccine. There's a lot of misinformation out there. And so the essence of my question is, who took the lead, and were leaders really visible? I mean, even senior leaders or your, physicians and nurses, you're automatic leader anyway. Just because
So from a data perspective, and again, I welcome any of the clinicians to jump in. I feel like one of the things that we really saw was leadership. Leading happens at all different levels. It can happen by the frontline team. It can happen top down, bottom up, side to side. There was a lot of entrepreneurial leadership. There was a lot of things have to happen. How do we get them done? The things that I would say we could learn from are that only top-down approaches aren't going to work. Only bottom-up approaches without leadership support are not going to work. There has to be clear messaging from and I would almost say like at every level, all the way up to central government. There has to be clear messaging about efficacy and safety. There has to be clear messaging about what the health systems policies are, about what the clinics policies are, so that by the time you have the front level people implementing on delivering something, they're very clear about their mandate, what they're doing, and the insight I think that we had was about the power of hyperlocal testimonials, and also the power of having these conversations be allowed to occur over time and invoking people's identity as a healthcare worker. Like, not very many people spend their time in the healthcare space in a service-oriented profession not wanting to do what's best for their patient in a way. So if you can invoke the identity of you're a healthcare worker, this is what healthcare workers do, it may be helpful from a facilitation standpoint, regardless of what people's other beliefs are or the barriers that they face.
Great, thank you. Very interesting discussion. I know it's a challenge. We found another challenge, you found another challenge, and I think that ability to grasp and use social media to get that message out, I think is one of the things that will help in the future, especially if you have a powerful message coming from below and above and supporting that effort. Very interesting discussion. Thank you.
Thank you. And I would just say, I think there are a few other co-authors on the call. So Carl or Sue, if either of you want to jump in and add anything, please feel free.
No, I mean, I think, one of the amazing things about this project is how quickly it had to be done and under what sort of pressure. I think, really thinking about how these kinds of products get used when they're being produced with the intention of being applied at the same time that you're analyzing data is an interesting thing to think about. But yeah, the rapidity was really an important feature.
And that was actually very, very important. So I will say, and I wish Katie Brown Johnson was on this call from the ESU because I want to give her credit for this, but we did the first 10 interviews and had feedback back to the program office within 2 months of getting this grant. So before the end of the VA fiscal year, which was in September, and before any of the vaccines were approved, and before people were making funding decisions about the next fiscal year, we at least had rapid insights about the need, the role demands on employee occupational health. And we changed some things by the time we published the paper. The first paper is in BMJ Open. Katie's the first author. The second one is in JGIM. We changed some things by the time we published them and had real, structured qualitative analyses, but we were pretty close on the first 10 interviews after 2 months. So, and that was using the Stanford lightning report method.
I think we have time for one more question. If anyone wants to hop off mute. Otherwise, I have a question related to what you just said. So how did you quickly engage people to interview like that quickly? How did your outreach take place?
Well, 2 of our core team members are occupational health leads at their site. So Wendy at Palo Alto and Sue Giannitrapani at Wilmington. And basically we talked to them, and then we talked to the 5 people they worked with, and then we talked to the 5 people they worked with, and then it kept going.
Okay. Well, thank you again, Karleen and Carl and Wendy. This is an exciting publication to read. And yeah, so honored to give you this award, and looking forward to hearing more about your work. A couple quick announcements, as Lisa's been putting in the chat. Monday, May 15th, next Monday, is Stanford Medicine Quality for Improvement Symposium at 3:30 p.m. in Assembly Hall. Hope to see you there. I think Lisa put in the chat that there'll be food and swag, so please stop by. And then we hope to see you at our next seminar series on May 23rd. At noon, and yes, hope to see you all there. And thank you again, Karleen, Carl, and Wendy.
And Sue, who's on the call.
And Sue, thank you.